everyone. Here we are today under the banner of IDEC Cafe, which happens every third Wednesday of every month. And today we have extremely uh, famous people who are working in gestational diabetes mellitus, and gestational diabetes mellitus is such an important topic, which is, I would say, a gray area for us. How more we know about it, more we get to thinking as to what more we can do in this area. So it's an unending knowledge, and I'm sure all of us deal with patients sometimes who make us think, what should we do? What should we choose? Whether I should overtreat or I should undertreat, or I do no harm or I do more to give benefit. And we have here two people who have a very good experience as well as academic inputs on this particular topic about the recent advances in gestational diabetes mellitus. I would request Dr. Sanjay Agrawal to say a couple of words, and then we'll start the topic by introducing the speakers.
Nirav, Nirav, you don't have to put my introduction. It's okay. Good evening, ladies and gentlemen, and welcome to this new edition of IDEC Cafe. We've had some great talks in the past, and we've got two astute speakers today who are so well versed with their topic. We know the fetal origins start right from the mother's womb, and that's where we are really trying to address the problem and see that how best women can be, managed for their glycemic control during pregnancy. And do we have new thoughts about this, the entire topic about pregnancy and diabetes? And nobody better than these two great speakers whom we have today, Usha as well as Chitra, who have done immense amount of work in this area. And I'm really keen to hear their thoughts. Both are coming up with two excellent topics, which are so different and yet interrelated to each other. So I'm going to hand this back to Anjali, and I'm hoping that all of you find this episode very, very interesting. And we'd love to, spend this next 1 hour with both of you.
So much. Let's kickstart with our first talk. Nirav, can I have ma'am's CV on the screen? So I am sure the people who are interested in managing gestational diabetes mellitus who have joined today do not need to get introduced to Dr. Usha Sriram, because she is the famous person who works in women's health in the country, and not only academically and clinically, but with her whole passion, I would say. And we all know that she is a senior endocrinologist, head and founder of DIVAS, which is a big organization who works on the all fronts to improve the women's life and their health. And she, I think, cannot be missed in any talks that happens with gestational diabetes mellitus, and she is going to enlighten us on the newer advances and recent advances or newer concepts in management of gestational diabetes mellitus. With that, I'll hand over it to Dr. Usha. Ma'am, it's over to you. I would like you to share your slides.
Sure.
And start the talk.
Thank you, Anjali. And first, I have to tell you what a great pleasure and honor it is to be part of IDEC Cafe, and especially to be, like I said, to virtually share the stage with Chitra Selvan, who is an amazing colleague in endocrinology and a great friend. And this topic, gestational diabetes, newer perspectives, I think is really something that I wanted to have a discussion with practicing physicians, because concepts are changing, and I think it's important for us to be in on what is happening around the world, and then of course how can we translate all this into what we do for our patients, what more we can do for our patients. So what I will do is go through these following things and talk about what are some newer perspectives in these areas. For example, definition itself may be changing. Some drivers and pathophysiologic basis, some newer understanding about consequences of gestational diabetes, screening recommendations, especially in early pregnancy, And as far as management goes, this is what Chitra is going to get into that area about HAPO follow-up and other things. But I'll just briefly touch upon what are the areas that are emerging. And then, like I said, the evolving oral hypoglycemic agent saga, particularly about what's happened to glyburide, what's happening to metformin, just a mention of it. And an area that I'm particularly very, very interested in is postpartum follow-up, which is really the area that I think where, as they say, the ball gets dropped. And then there is obviously a much greater risk of type 2 diabetes and cardiovascular disease and other complications that happen to mothers. So one of the things that right off the bat I want to establish is also, when we talk about pregnancy, and I was a bit intrigued by the title of Chitra's talk, which is, are we medicalizing pregnancy? Because the number one medical complication of pregnancy is gestational diabetes. But is it really a medical complication? And I'll, talk about that very briefly. So the global estimates of the prevalence of hyperglycemia in pregnancy. So the IDF Atlas says as much as 1/4 of all births are affected by hyperglycemia. So here, there's a lot of confusion about what is HIP and what is DIP and what is GDM. So I wanted to get that cleared, and that's a somewhat of a new perspective because we keep throwing in these words, terms, HIP and DIP and GDM and pre-GDM. So pre-GDM, pre-gestational diabetes, is a completely different thing. And in that, it could be type 1 or type 2 or other forms like MODY and cystic fibrosis induced or steroid induced. So all of that is pre-gestational diabetes. Then there is this hyperglycemia in pregnancy, which is an umbrella term for if you have either diabetes in pregnancy or overt diabetes during pregnancy, which is what is called as DIP. And then there is GDM, there is GDM, which can be early GDM, or when we typically used to diagnose between 24 and 28 weeks, which is standard GDM. So this is how, when I was in medical school and subsequently until recently, we used to define GDM irrespective of whether OHAs or insulin was used, and irrespective or if it, it could have antedated pregnancy or if it persisted after pregnancy. So everything was just put into this simple definition. But then we kind of learned that there is this true blue gestational diabetes. So this is now considered a distinct entity that we diagnose in that 24 to 28 weeks, because that's when all the pregnancy hormones are peaking. And it makes sense that the insulin resistance would be the maximum at that particular time. And therefore, this unmasking of this glucose intolerance at that time, that is really the true blue GDM. And if we picked up something early at first booking or early in pregnancy, that's really probably something that was already there. So that's kind of how we are looking at it now. So Dr. David Simmons gave his Banting lecture a couple of years ago. So, and he is coining now two new terms. He's saying there is something called as prevalent GDM and incident GDM. So people who get diagnosed in the first trimester, for example, this is prevalent GDM. These are people, this was probably, there was some pre-existing hyperglycemia, pre-diabetes, metabolic syndrome, or even frank diabetes. All of them, then they entered the pregnancy. That is prevalent GDM. And the ones that we diagnosed later on is the incident GDM. So I just wanted to put it out there that the pundits in GDM are also thinking in terms of this two distinct types. That still seems to be what we have already known, which is family history and obesity and PCOS and previous big birth of big babies, unexplained, stillbirths, multiple pregnancies, all of these things, maternal hypertension, metabolic syndrome. These are all the things that we know are driving gestational diabetes. Add to this now understandings about social determinants of health, that women living in lower, in congested areas or polluted areas, or women living in poverty, these are all people who are also developing more gestational diabetes. Also mentioned the microbiome theory. Gut microbiota are implicated literally in everything. But here I just want to show you, what happens in the normal microbiota. And, if there is weight gain and insulin desensitization, and in the third trimester, what happens is altered microbiota. So when this insulin desensitization is happening, that, gestational diabetes risk is higher. Just want to mention that to you. Now, as I started my talk and said, what is GDM? Is it a medical complication of pregnancy, or is it a pre-existing condition? So if it's a pre-existing condition, we cannot call it, we are medicalizing it. It's there, and it's a condition like asthma or hypertension or seizures or any of those things. You actually have to treat it. So GDM is actually a chronic cardiometabolic disorders that identifies women who have an elevated lifetime risk of ultimately developing type 2 diabetes and cardiovascular disease. So this is just getting more unmasked during the pregnancy, because we know now that pregnancy is a stress test. So many, physiologic changes take place during pregnancy that it actually is a stress test. And people, if they are not starting out healthy, for example, they're overweight, they're pre-diabetes, or they have a family history, or a mother with GDM, these are all people who are already marked, and they have this before they got pregnant. I'm going to show you a cartoon for that. So the best part of this is in identifying high risk women early in the natural history of these conditions. The diagnosis of GDM raises the tantalizing possibility of early intervention and risk modification. So this is a fantastic paper by Ravi Ratnakaran and Jennifer Fu. They called it the life course perspective of gestational diabetes, opportunity for prevention of diabetes and heart disease in women. And particularly, this is Heart Disease in Women Month. So I'm really happy to, talk about this and mention this. So we always have this question, is GDM a matter of insulin resistance, or actually there is insulin insufficiency? Meaning, if you are healthy and if you can mount the extra insulin that you need, then insulin resistance is part of normal pregnancy. But if you're not able to mount that, that means you're actually having some degree of insulin insufficiency. So in the same paper by Ratnakaran and Fu, they have this fantastic graph where you can see before pregnancy itself, these people with GDM, right, their beta cell function is dropped already. And then you can see that it is dropping further. And whereas in healthy people, they are able to normalize everything after pregnancy, these women, they continue to have a downward trajectory. So, which is why I want to go back to this really important statement, that is it a medical complication of pregnancy, or are we dealing with a pre-existing condition? So in the same paper, they also, Ratnakaran in another paper a few years ago showed that women who have GDM have, the decline in LDL and greater decline in HDL in the years before GDM. So their cardiometabolic risk factors are there even before many years before the pregnancy. And Dr. Yagnik has actually shown this in his Pune cohort as well. So what about this other driver? Is it gestational weight gain, or is it the pre-pregnancy BMI, or they both matter? Because many people say if once you've become pregnant, whatever happens after that, it really doesn't matter, right? But I just want to show you recent retrospective cohort of Malaysian women showed that overweight or obesity and age, of course, were identified with a 2.5-fold higher risk of GDM. However, excessive gestational weight gain during the second trimester in these women further increased their risk of developing GDM, and other studies have confirmed that. So, restricting weight gain during pregnancy is something that we must enforce in our pregnant women, because repeatedly, studies are coming out showing that gestational weight gain is a big risk factor. Also, if you see this, after the first pregnancy, if they gain a lot during the first pregnancy and they retain that weight after that, then during the second pregnancy, they're already starting out bigger with a higher preconception BMI and excess gestational weight gain. Fat mass is higher, metabolic consequences are greater. Things they can have things like preeclampsia, and this goes on, and then obviously later in life they go on to have type 2 diabetes and cardiovascular disease. So here I just want to quickly pause and say, when we talk about later in life, in these women we are talking about a 50 to 70% increased risk of type 2 diabetes in the 5 to 10 years after index pregnancy. So if they are in their 20s and 30s, you can imagine they are going to get type 2 diabetes and early cardiovascular risk in their 30s and 40s. And then we never associate birth defects with gestational weight gain. So one of the things that I really want to again emphasize about preconception weight optimization is it's been shown now that this birth defects seem to be associated in women. So the association between GDM and birth defects may be in part due to undiagnosed metabolic disorders associated with obesity, such as pre-gestational diabetes, rather than it's a form of pre-GDM, and highlight the need for increased efforts for pre-pregnancy screening, both for undiagnosed diabetes and obesity in women of childbearing age. Moving on to consequences of GDM, all the usual increased risk of preeclampsia, and then they have to have induction of labor many times, operative deliveries, complications during the operative delivery, labor complications, and then postpartum, like I said, recurrent GDM and type 2 diabetes, cardiovascular disease. And offspring, of course, I've just talked about, birth defects, if this is early GDM, neonatal complications, which we know is a big list, and long-term outcomes in children of mothers with GDM, like obesity, visceral adiposity, diabetes, metabolic syndrome. But I want to show you a few more new ones. So cardiovascular disease, again, shown by Baiju Shah and Ravi Ratnakaran, increased risk in women with GDM. Increased risk of type 2 diabetes, 10 to 11-fold higher risk of type 2 diabetes. And we also know about that both the Barker hypothesis and the Pedersen hypothesis are at play in women with GDM. So if they have low birth weight for any reason, or if they have macrosomia, all of these again increase the risk of complications, both in mother and in the child in the future. So one of the things we have to do is optimize birth weight, and this is the only way we can decrease NCD burden. So two new things I want to highlight is not only are the things happening in terms of diabetes and obesity, but what's happening to the newborn is also neurodevelopmental issues. In babies born to mothers with GDM, they may have lots of initial issues like feeding issues and postnatal complications, behavior issues. But then let me show you fetal brain development. So in this, very clearly they've shown the influence of gestational diabetes on neurodevelopment of children in the first 2 years of life and subsequently. So obviously, this maternal hyperglycemia and what they call the excess of fuel teratogens actually has a imprinting effect on the brain of the developing child and increased. And we know now that maternal obesity seems to be a risk factor for autism in children and autism spectrum disorders. Now, another new one, which is non-alcoholic fatty liver disease and GDM, strongly associated with non-alcoholic fatty liver disease. And in this multivariate adjusted model of women with GDM history, 903 retrospective analysis, in the unadjusted, they found an odds ratio of 2.97. So what you can look at this conversely. If you have a woman with GDM, she could be someone that you can monitor and follow up for non-alcoholic fatty liver disease. So, and we know that is becoming something very, very important. And I cannot, stress the importance of knowing about cardiovascular risk in women with GDM. And I just want to show here how, whether it is A1C or fasting glucose or cholesterol or LDL, every one of these things are abnormal in these women who go on to develop cardiovascular disease. And not only I showed you a slide that it can happen pre-GDM and postpartum, they seem to have change in the CV risk factors over time in GDM and non-GDM. Per year, all of these things keep changing in these women. And then a newer understanding is, this is, hot off the press just a year ago, the birth of cardiac disease in children born to mothers with gestational diabetes. So birth of cardiac disease, mechanisms linking GDM and early onset of cardiovascular disease in offspring. So you can see how everything from epigenetic changes to mitochondrial biology, to nitric oxide metabolism, germline alterations, all of these things, fetal life, then in postnatal, what happens, adolescence. And so the children are also at greater risk for cardiovascular disease. So again, I think fueling the theory that GDM is the mother of NCDs. So we think of GDM as this high glucose in pregnancy. That's just the tip of the iceberg. Below that is lying this adverse CV risk factor profile. So we need to keep that in mind. So one of the reasons, as Anjali brought out right at the beginning, that this subject, GDM, is always, hotly debated, constantly evolving, changing guidelines, is partly because we have all these professional societies, all great ones, but all looking in different directions, have come up with their own recommendations. And that hasn't happened in the non-pregnant diabetes group or non-pregnant, let's say, lipid group or anything. Here alone, there seems to be a lot of disagreement. And one of the things that happened was the HAPO study, about which Chitra will talk about in detail, which kind of, changed things on its head, showing us that there is no inflection point, that this is a continuum. As the sugars go up, there is increased risk of, the perinatal complications. And of course, things were revised. And then after that, as you can see here, different professional societies have different guidelines. But just to show you overall, I think we are very close to being on the same page, meaning everybody is recommending pretty much universal screening, not selective screening. Most people, are recommending a 75-gram 2-hour oral glucose tolerance test. And if you look at, guidelines like NICE guidelines may still recommend selective or based upon risk factors, because we know that NICE is based upon more on, economy based, and other guidelines a lot on insurance and market driven and other things, and evidence based. So if you look at DIPSI, which is our national recommendation, it is universal screening, must screen at first booking, and again, if that's negative, at 24 to 28 weeks. They also recommend a one-step 75 gram. They say that you can do it fasting or non-fasting. And if the 2-hour value is 140 or more, it is gestational diabetes. So my recommendations are, who should you screen? Every pregnant woman. Why? The consequences of GDM and benefits of treating and HAPO data. When? At first booking, again at 24 to 28 weeks. And how? Of the 75 gram glucose tolerance. And this is what the DIVA's mantra is: test all, test early, test again if the early is negative, test correctly, because we just seem to be doing this complete hodgepodge of things, using one thing for first trimester, another thing for second, another thing for third, or take one from this and one from this. So it's not evidence-based anymore. It seems to be very convenience-based. So we need to move back to evidence and stick to testing correctly. And most importantly, test what we say in the fourth trimester. The fourth trimester is actually the postpartum period up to the first 12 weeks after delivery. So that is. Are there any biomarkers for early detection? And just to show you, there are lots of work is being done in both serum and urine biomarkers. They've not been, there's false positives and false negatives. So we are still not there yet, but a lot of work is being done in early biomarkers. One thing where I think there is not much of controversy, and we are very, very convinced, is that treating gestational diabetes correctly, of course, improves perinatal outcomes and pregnancy outcomes, as you can see from this, clearly favors intervention for all of the parameters. Should we treat them in early? There is a big study that is going on called the TurboGM, treatment of booking onset gestational diabetes. That is TurboGM. And what TurboGM has shown is that if you if you don't treat, these women tend to, more of them develop gestational diabetes between 24 to 28 weeks. But if you treat too aggressively with, let's say, even medical nutrition therapy, you may run the risk of low birth weight babies. So that's also something we have to be very cognizant of. So in the management, medical nutrition therapy, number one, because as much as 60 to 70% of women can be managed just with MNT. Gestational weight gain management, again, something that we don't stress at all, because we have done an audit of records of OBGYNs, and you'll be surprised that very few of them have BMI recorded. Height, weight, BMI, because all calculations and everything and recommendations are based on BMI. And we are still very steeped in, socio-cultural norms and traditions and things like that. So what people eat and what they do, physical activity, again, based upon a lot of socio-cultural norms, allowing the pregnant woman to do exercise or walk or be active, self-monitoring of glucose. I'll show you what's the new thing. And then pharmacotherapy. So the Institute of Medicine guidelines are these. And I just want to say that we need to adjust this from a new perspective, I'm saying, for Asian cutoffs. So look at BMI of 18.5 to not 24.9, but to 22.9. So, that would be a person who is normal. Person who is 23 to 25 would be overweight, and anything more than 25 would be obese. So you can see that these weight recommendations should be applied to them, And if you look at it that way, a person with a BMI of more than 25 need not gain more than 5 to 9 kilos. So how often is that happening? So that's something that we need to balance. The targets remain the same, though Dipsy says we should really aim for a fasting of less than 90. And a recent paper showing that 1 hour postprandial of less than 120 is good. It's just, very, very recent. I'm waiting to see more papers on that. 2 hour postprandial less than 120. But when CGMS was looked at, what they found really was that fasting sugars in a normal healthy woman is actually below 80. A 2 hour value on an average is actually below 110. And if you look at, a 1 hour value is rarely more than 120. So this is what, people have looked at. And when they have designed things like the time and range concept, which is something new, and whenever possible, we should be applying this. Obviously, it is not something that is affordable for most. And the thing about pregnancy is because it's a dynamic thing and things are changing from 1 week to the next or 1 trimester to the next, we cannot apply the results of a 2-week reading from last month to this month. Things will be changing, so this will have to be continued. But just to show you that in pregnancy, in gestational diabetes, the target range is between 60 to 140, and we expect the greatest percentage to be in the target, and a very small allowance for people to be obviously below the range and above the range. It's a little bit less tighter for people with type 1 because they have a greater risk for hypoglycemia and increased risk for vasculopathies. And once we have done this, we have to decide when do we move on from medical nutrition therapy to pharmacotherapy, which I just want to say here most people seem to be in agreement. If the fasting sugars are more than 95 for sure after a week or two of MNT and a 2 hour value more than 120, we should consider pharmacotherapy. So really insulin is the gold standard, because the American College of OBGYN as well have said strongly endorse insulin as the preferred first line therapy, with the recommendation that oral hypoglycemic agents be reserved for women unable or unwilling to use insulin. And the ADA standard of care, the HOT 1 2022, also says insulin is the preferred medication for treating hyperglycemia. Metformin and glyburide should not be used as first-line agents, as both cross the placenta to the fetus. Other oral and non-insulin injectable glucose lowering lack long-term safety data. So I'll again defer to Chitra because she's going to talk about metformin, I'm sure. Just a quick word. Glyburide, for all practical purposes, has been relegated to a level 3 or even lower because of increased risk of hypos, NICU admissions, and maternal weight gain and such complications. So it's been moved away. And as far as metformin, we can have in the discussion time about the role of metformin. Just to say that it is as effective as insulin based on the MIG study. Patients preferred it because it's a pill as opposed to an injection. Nearly 50% required insulin also. But really what is important is what happens to the babies whose mothers received metformin. We'll wait to hear from Chitra. My last few slides, postpartum follow-up. We cannot forget this phase because I think here is where we can do a lot of good. We have to try to prevent GDM. Is it possible? We should try. But at least definitely we can prevent diabetes in women who have had GDM. And repeatedly studies from India have shown that we are at very high risk for type 2 diabetes. And globally and in our country, only as much as 20 to 25% of people come back for follow-up. And there are many, many reasons why that happens. And the guidelines for that also, there's some variations, but most people look at this. They say 6 to 12 weeks after delivery, you do a 75-gram OGTT, apply non-pregnant criteria, and call it as either diabetes or pre-diabetes, or as normal, and proceed from there. And this is a algorithm that we have developed where you can see you must discuss risk for diabetes, encourage breastfeeding because that's been shown to decrease future risk of type 2 diabetes, schedule postpartum follow-up, 6 to 12-week postpartum visit, again, determine the family planning and do the test, and depending on what they have, then we proceed with treatment. Earlier, the ADA and others said you can follow them once in 3 years. I think that's way too late. We must follow them every 6 monthly to 1 year. So there was a study done by Dr. Catalano and Brew, said, why don't we see them immediately before they go home, check the placenta is out. Why don't we check and see what happens to them and see if this test correlates with the 4 to 12 week later test, and that would take away a lot of the difficulties and barriers. Unfortunately, again, there are some women who tested negative here, tested positive at 6 to 12 weeks, some who tested positive here, tested negative at 6 to 12 weeks. So as of now, the jury is out, and it looks like we need to do this is the one that we need to do the 6 to 12 week postpartum. So prevention of GDM, the radial study showed that women with GDM, if you do intensive lifestyle intervention, you can decrease the risk of GDM in the next pregnancy. And studies have clearly shown that weight gain, again, decreases the risk of, weight loss, decreases the risk of type 2 diabetes in the future. Physical activity definitely benefits and decreases the risk of GDM. I would encourage everyone to read this paper. It's a very important public health approach. And so this is my summary slide, which tells us the current challenges and gaps in care. To me, the biggest gap is preconception care, preconception counseling, optimization of risk factors, maternal nutrition, reduce maternal obesity. And then in the first trimester, identifying pre-existing diabetes, early detection of GDM, novel biomarkers for future. Then what do we do with the second and third trimester? You can see, how do we treat? We pick them up, optimizing gestational weight gain, the importance of epigenetic effects in offspring, and how to reduce intergenerational effects. Encourage breastfeeding, postpartum screening, and lifelong diabetes prevention. Because ultimately, we have always looked at pregnancy with that narrow lens of the baby. Baby is very, very important. I'm saying we've only looked at it as delivering a healthy baby, a safe delivery. We've never had the mother in our radar at all, especially mothers' long-term risk of diabetes or chronic disease or heart disease. And look at this one. Every time there is a GDM pregnancy, her risk puts her in a higher trajectory for future chronic disease. And same for the offspring as well. So my thing is that every baby actually deserves a healthy mother for the long term. And so on that note, I want to say thank you again to IDEC Cafe and Anjali and Sanjay and Neeta. Thank you so much.
Thank you so much, ma'am, for that message of earlier we pull the string of starting the intervention. I think longer we are going to reach in achieving the better outcomes. Yeah. So I think we'll start with Dr. Chitra's talk, ma'am, and then we have a good half an hour later to have. There are so many questions coming in chat box and in my list. So again, Dr. Chitra, one of the very prominent figures who works for women's health and talks very passionately about it. We know that HAPO was the landmark study which changed our attitude towards looking at the pregnancy and provided some numbers, though we still like to have some controversy about them. But I think that was the landmark thing that changed our evidence-based practice in managing gestational diabetes mellitus. And now we have a long-term follow-up of HAPO study and some more insights into how we manage our gestational diabetes better. Over to you, Dr. Chitra, for a wonderful talk.
Thank you, Dr. Anjali, and thank you to the team at IDEC for inviting me to be a part of this session. And I absolutely love sharing the stage with Dr. Usha anytime. So the topic, Dr. Anjali's brief was to give me something which will get people to sit up and take notice, which is edgy. So, and that's why I chose that the topic should be, are we over-medicalizing pregnancy? This topic is in direct response to an article which was published in the NEJM about 2 years ago to say something to the effect that using the older cutoffs for the diagnosis of gestational diabetes did not necessarily affect pregnancy outcomes, and the fact it again rekindled that conversation about whether we were doing too much with the IDPSG cutoffs for diagnosing GDM. But now it's been close to 13 years since the new cutoffs came and since the original HAPO study has been published, and what have we learned from there, and what does the future look like, right? And this conversation is extremely important to have because we are currently sitting on a ticking time bomb where the prevalence of obesity and diabetes is exponentially increasing, not just in adults, but also in adolescents and children. And as we try and find public health measures to mitigate it, it might also be important to be looking at fetal origin of these conditions, which are traditionally said to be adult conditions, but it's not restricted to that population at all anymore. So if I was going to ask you to guess, what do you think is the prevalence or incidence of hyperglycemia in pregnancy continent-wise, and take a guess? Would it be somewhere between 25? Would it be 50? Would it be 10? Would it be 30? There is evidence to suggest that Southeast Asia has one of the highest prevalence of women who have hyperglycemia. And Dr. Usha did take us through the complexity of what this entire umbrella does include. But roughly 1 in every 4 pregnant women living in our part of the world is at risk for hyperglycemia, and that's how common it is, right? And we do have one school of individuals questioning that. That's only because you lowered the cutoffs for diagnosis. Of course, our prevalence is going to be high. So that's the premise that I'm starting from. All along, we've known that overt diabetes during pregnancy is associated with significant outcomes which are adverse, both for the mother and for the child, but that is in a mother who has diabetes. And throughout, we were with the opinion that maybe all hyperglycemia levels, which are lower than what is overt diabetes, could be harmful for the pregnancy, for the child. But we didn't really know how low is normal, right? But as Dr. Usha did show us, what is normal blood glucose levels for a pregnant woman now that we have continuous glucose monitors available is much, much lower than what we would expect in, let us say, a non-pregnant individuals. So the thresholds of glucose levels alter in pregnancy. It's normal physiology because you now have the fetus, which is continuously drawing glucose from the mother. So essentially, in a fasted state, the mother's blood glucose level should actually be lower than what it is in general population. And we do know that time in range is defined as a value above 63 or so, right? And that is low as compared to an individual who's not pregnant. And it's also a condition where there is increasing insulin resistance between to the gestational ages. And we do know that with that increasing HbA1c, with that increasing time duration, insulin resistance does increase with time. We all do understand that rising HbA1c does lead to increased risk of adverse events, and that HbA1c cutoff seems to be somewhere between 6 and 7, and that's from where stems the cutoffs for us to decide what might be good glycemic control for individuals with diabetes, right? And we don't know the numerous adverse effects that occur. But what about gestational diabetes itself? Are we worried only about pregnancy outcomes? Dr. Usha did show us that, yes, there seems to be clear evidence in almost all the different groups or all the different stakeholders here, including gynecologists, endocrinologists, physicians, diabetologists, do all agree that pregnancy outcomes are severely affected by blood glucose levels, which are not as high as overt diabetes. But the other outcomes is something that we are trying to find evidence to convince ourselves. So if you notice over the years, the diagnostic criteria has come much lower, especially the fasting glucose value. And the other significant difference which happened with the IDEC criteria is that you did not need to have two abnormal values for your OGTT to be deemed as showing GDM. You just needed one value. And the fasting value dropped from 95 to 92, whereas the second hour value dropped from 155 to 153. Now, for busy clinicians, this might look like such a small nuance of a number. Why did you need to make this change? Why do I have to remember these numbers? And what is the end result out of all of this effort, right? But the other important difference with the IID-PSG is that you need only one abnormal value for you to make a diagnosis of GDM. So much of the IID-PSG cutoffs came from this important landmark study, which was published in 2008. They set out with one primary question, which is, if the blood glucose levels are lower than the diabetic range, but higher than the normal range, does it affect pregnancy and the neonate? That's all their question was. It was a large study, 23,000 and odd individuals, multi-center, multi-country. What they did was they did a 75 gram OGTT between 24 to 32 weeks of gestation. The data remained blinded if the fasting plasma glucose was 105 milligrams per deciliter or less, and the 2-hour plasma glucose was 200 milligrams per deciliter or less, what they recognized as overt diabetes. And in all other situations, it was kept low. And what they looked at was assessing the Pedersen's hypothesis linking maternal glycemia with fetal hyperinsulinemia to neonatal adiposity. So the primary outcome was increased birth weight, increased cord blood C-peptide, cesarean section, neonatal hypoglycemia. Secondary outcomes were prematurity, birth trauma, admission to NICU, preeclampsia, and hyperbilirubinemia. Okay, and they broke the analysis down to 4 different categories. Notice that category 1, that is the lowest quartile that they looked at, the fasting values were less than 75, very similar to what was shown as to be normal in the CGM studies in pregnant women. 1-hour value was 105, 2-hour value was less than 90, very similar to the graph where Dr. Usha showed us that normal 1-hour values are usually less than 120 in normal women with no insulin resistance. And what they showed was here that there was a continuous and a strong association between rising blood glucose levels above that category, which I showed you, which is 75 fasting, 105 post-meal, with birth weight, chances of having primary cesarean section, chances of the child developing neonatal hypoglycemia, and also chances of the cord blood C-peptide being greater than 90th centile. The cord blood C-peptide is an indication of neonatal hyperinsulinemia. Neonatal hyperinsulinemia occurs because maternal blood glucose levels crosses the placenta, goes to the baby's pancreas, and stimulates C-peptide production. So that is a indicator of the exposure to glycemia in the immediate time window before birth. And the odds ratio for all of the primary and the secondary outcome were significant for fasting 1-hour and 2-hour values in the categories that they were looked at. And it was a continuous value. And if it was continuous, how did they arrive at the IID-PSG cutoffs for GDM? They arbitrarily chose an odds ratio of 1.75, and whatever were the corresponding fasting 1 hour and 2 hour values, they chose that as the IDPSG cutoff. It had to make public health sense. It also had to make cost effectiveness and feasibility sense. And that's why it was chosen and that's why the cutoffs moved from 95 to 92 and 155 to 153. But the science behind it remains that there was a strong correlation, which means that if you choose an odds ratio of 1.5, the cutoffs go down further, right? So that's how we arrived at these diagnostic cutoffs. And why should we talk about this study? Primarily because this is linking all the cutoffs to outcomes as compared to any other study or any other cutoff which is available there in literature. So coming to the question, are we now simply just making diagnosis of GDM and making our own lives more difficult? Or does the management of GDM in the mother improve metabolic outcomes for the newborn as well? Dr. Usha wanted you to focus on the health of a mother, about how a healthy mother is absolutely something that every child requires. But now I'm making the case for diagnosing GDM in the mother to make sure that we bring down the global burden of obesity and hyperglycemia in adolescents and children born to mothers who had GDM during pregnancy. So that's where the HAPO follow-up study comes in. This was published in 2019, but right after the publication, we had the COVID, which took over all of our imagination and bandwidth, which necessarily meant that important areas of research like gestational diabetes didn't probably get its worth. And I believe this paper did not get all of the attention that it required. What this study did was a very, very simple study. They took about 4,000 and odd children who were aged between 10 to 14 years of age, okay, who were now 10 and 14 years of age, and whose mothers had had a 75-gram OGTT at 28 weeks of gestation, right? So this study was published in 2019. So if the children are 10 to 14 years ago, the OGTT was probably done in 2008, 2009, when we were not using the IDPSG criteria. So what they did was they took the mother's OGTT, used the WHO criteria, where you need 2 abnormal values and the cutoffs are slightly higher. And then they divided the mothers into 2 groups, mothers who had GDM, mothers who did not have GDM by the WHO criteria. And now the children are 10 to 14 years of age, and the children got an OGTT now. And they tried to look at whether the children had impaired fasting glucose, impaired glucose tolerance, or type 2 diabetes. All right, okay. So this is what they found. What they found was that mothers who had GDM, that one bit of information correlated with the incidence of impaired glucose tolerance with children. The odds ratio seemed to persist even after we adjusted for other confounding factors. And this is an important bit of confounding information. The BMI could be different. The child's BMI could be different. The maternal BMI could be different. The family history could be different. So even after adjusting for all of these various confounding factors, it was clearly seen that the maternal GDM status did correlate with impaired glucose tolerance in the children at the age of 10 to 14 years of age. So for mothers with GDM, 10.6% of children has IGT, had compared to 5% of the children whose mothers did not have GDM. Fasting glucose was 9.2%, and impaired fasting glucose was 9.2% and 7.4%. The odds ratio after adjusting for family history, maternal BMI, child's BMI were 1.09 for impaired fasting glucose, so it did not reach importance, but for IGT, it did. So this essentially shows that GDM did not only correlate with the impaired glucose tolerance, but also with indices for insulin sensitivity and oral disposition index in children who were 10 to 14 years of age now. So that's one bit of information. And that's probably why what we do during pregnancy has long-lasting consequences to the offsprings. And long-lasting changes in their metabolism and their epigenetics and programming, which could have effects which could explain the increasing prevalence of metabolic conditions. But that was the WHO criteria. The IDEC-SG is slightly more stringent. Is it too stringent? Is there any other study which has looked at similar findings using this criteria? Because the previous study did use the WHO criteria. So this is the follow-up of the HAPO study, where the cohort of women who were included in the HAPO study were followed up now, and the child's metabolism was again looked at. A similar study, but here they were actually the women who were recruited in the HAPO study itself. So around 4,700 people, and the children had a BMI calculation, and they also had glucose outcome data done. Again, I want to reiterate, we are going to see results as categories, category 1, category 2, category 3, and so on. Category 1, which is the lowest, the fasting value in the group was less than 75. The 1 hour value was less than 105, and the 2 hour value was less than 90, right? And you should think about the thresholds at which we are ready to initiate insulin in women with GDM. We don't start till it is 90, and 90 will be category 3. Keep that in mind as I show you category-wise results of outcomes in children. And these are the glucose levels of children across the categories, the 5 categories described here. Notice that the risk of blood sugar levels going high jump up significantly at category 2 itself. In category 2, we are talking about blood sugars fasting range of 80 to 85. And this holds true for fasting glucose, this holds true for 1 hour glucose, and the 2 hour glucose, including the A1C. And they also went on to study the Matsuda index. Matsuda index is an index which is used to assess insulin resistance. So you see that there is a negative correlation or an inverse correlation between mother's glucose and child's insulin sensitivity. They also looked at disposition index in the child. So again, reiterating that the cutoffs as designed by the IDEC-SG are values which are relevant. They have long-lasting effects, again, with correlation with the child's fasting glucose and A1Cs, and also the maternal fasting 1 hour and 2 hour postprandial were inversely associated with the insulin sensitivity and also with the disposition index. And all of these associations were again corrected for confounders, which are predominantly maternal in child BMI by itself. So across the increasing categories of maternal glycemia, there seems to be rising insulin resistance and rising blood sugar levels as well. So going back to the question, do we base our diagnosis and management of GDM on what we believe has traditionally been something that we all believed in, or do we base it on outcomes which are relevant? I think it's important that I think we'll all agree that we should definitely base it on outcome. While we were looking at pregnancy and neonatal outcomes, we now have enough data to suggest that what we do during GDM as physicians and diabetologists has effects on the child. There's evidence to show the same, that not only in the immediate pregnancy and neonatal outcomes, we also do know now the offsprings who are exposed to GDM in utero are more insulin resistant as early as 10 to 14 years of age. They will be being followed up. We will be collecting data about what is going on, let's say, as they touch 20s and 25 years of age. And it's not surprising that the same continent or the region of the world with the highest prevalence of hyperglycemia in pregnancy also seems to have the highest prevalence of diabetes in the entire world. So this is something which I think everybody interested who's a stakeholder in this context should be paying attention to. Pediatricians, gynecologists, public health specialists, policymakers, doctors, and everybody itself. So the title was supposed to intrigue and get you hooked. We are definitely not over-medicalizing hyperglycemia in pregnancy. We are definitely under-recognizing and under-treating it. If this were any other issue, we should have had a reviewed or a revised guideline. for all of it, but for various reasons, because gestational diabetes has differing groups of people who are interested in it, and then it is very difficult to get all of them on the same platform. The movement towards concrete change has been slow, but it's important to know that we are sitting on proper evidence to suggest that what we do during pregnancy has long-lasting effects. This might be slightly archaic, but this is the St. Vincent's Declaration, which said that the intention was to improve pregnancy outcomes of women with diabetes to the level of those with non-diabetic population within 5 years. It's been many, many years since we said this, but this was about women who had diabetes. But we do know now there is several other entities related to hypoglycemia and pregnancy, which can have long-lasting effects on the health of the offspring itself. And that's the end. And I hand back over to Dr. Anjali and Dr. Sanjay.
Wonderful presentation by Dr. Chitra and Dr. Usha ma'am. We have few of questions. Before that, I would like to say hello to Nitin sir, who are here.
Hi.
Hi, Nita.
Hi, Usha. Nice to have you here.
Nice to be here.
So let me kickstart the questions to both of you. Very interesting lectures. I must compliment, wonderful lectures that you have brought out, very thought-provoking, questions and answers. Both of you have not touched on the role of glycemic variability and hypoglycemia in pregnancy. And I was kind of wondering whether there is any data out there. What happens to people who get recurrent hypoglycemias or asymptomatic hypoglycemias, particularly since they are on insulin therapies, as well as, people who get a lot of glycemic variability. So, we've been talking only about hypoglycemia. I understand the context of the entire lectures, but do we have data to suggest what happens to these people and the offsprings post-delivery?
So, I'll chime in first. So typically it's it's conventionally thought that mothers tolerate hypoglycemia better during pregnancy. The teleologic explanation is that God designed it that way. So because there has to be diffusion of glucose going to the baby, and therefore mothers are supposedly they handle hypos better. Having said that, there's old data showing that that even mild hypoglycemia, especially fasting hypoglycemia, can increase the risk of ketonuria and can affect IQ of the baby. Is something that we have long understood. But more severe hypos, of course, can definitely interfere with the fetal well-being and can lead to pregnancy-related complications. So, in mothers who are on therapies with insulin, one will have to be. That's why I showed the time and range, and the range that they are allowing anywhere from I think 60 to 140. So and if they are type 1 or type 2, if it's pre-GDM, it's a little bit more relaxed targets. We want to avoid the hypos. With the CGMS data, there's much more CGMS data now on pregnancy, and that's what we showed, that in normal healthy pregnancy, the numbers are a lot tighter, a lot lower. So ideally, we should try to get as close to that, provide without causing hypoglycemia. So there is no official recommendation on glucose variability, but there is on hypos and hyper and what should be in the normal range.
So do we have a cutoff points for diagnosis of hypoglycemia, like we say for 63 or 17 non-pregnant women? And consider the fact that glycemia, normal sort of cutoff points are lower in pregnancy. Do we have defined sort of, cutoff points to say what constitutes a hypoglycemia, or is it just symptomatic hypoglycemia that you talk about?
We are talking about symptomatic hypoglycemia. If
so is there a cutoff figure that you would say is hypoglycemia, like in non-pregnant state?
I would consider anything below 50 as being of concern in a pregnant woman as opposed to a higher number in a non-pregnant person.
Chitra, you want to say something? You're not audible.
I'm not muted. So one study did look at hypoglycemia post OGTT, where 70 was said to be a cutoff which correlated with a low birth weight or IUGR kind of decreased head circumference kind of a scenario. But we do know that pregnancy is a state where there is ketones and all of the other non-glucose sources of energy. So mostly women do tolerate, you and I both do know that. But 70 is one studies cut off to say there was hypoglycemia post-OGTT. I'll have to take a look at Dr. Nitin's paper to see what he has to say.
Nitin is here. Nitin, you would know this?
Yeah. So this was a study that we did a couple of years ago when we did not have FGMS, but we had the CGMS, and we connected it for 3 days at that time. And what we found was that there were controls who were non-diabetic in this study, and 4 out of 10 of non-GDM women also had hypoglycemia defined less than 70. Whereas, so that what Dr. Usha mentioned, that it can really be low even in physiological pregnancy. So something like 55 is what we thought was worrisome, but subtle hypoglycemia did not have any outcome impact on the mother as well as the fetus that we followed up. This was a small study, about 40 patients.
Yeah.
I guess we need to be more worried in patients with type 1 or long duration diabetes before pregnancy who are likely to have some baseline autoimmune dysfunction, where I think these people will be more prone to develop hypoglycemia because of the baseline morbidity of diabetes rather than hypoglycemia, which is related to stronger treatment of gestational in its blue form, as Dr. Usha said. Ma'am, because we're talking about TIR, there is no right or direct recommendation as to what is considered as the right cutoff for TIR that we have during non-pregnant people who are getting either a continuous glucose or a flash glucose or even multiple glucometer readings. So what you would say in clinical practice would be an acceptable TIR during gestational diabetes?
There is
in either type 2 or gestational diabetes. What is the TIR that we can consider as clinically accepted number?
No, I showed a slide where the range.
Yeah, they mentioned that there is no right now a strong data to suggest that there is a number. Higher you achieve, it's better. That's what I think the graph as well as
what percentage of the thing should be in the range,
and what is acceptable?
It's pretty high in the 92 to 93 range because only 3-4% hypos are allowed, and then obviously hypers are also in that very short narrow range. So we need to get that into the bigger 90%. Percentage has to be in the normal range. It's a lower number for people with pre-GDM. Because especially type 1s and type 2s, because in them you obviously don't want strict targets, such a strict target.
Right. There is a question in the chat box which says, what is the role of anomaly scan in patients who get accidentally pregnant on with uncontrolled diabetes?
100% they have to get an anomaly scan because we don't recommend termination for anyone ever. Everybody is counseled on, you proceed with the pregnancy. We will do an anomaly scan and a fetal echo and also the quadruple scanning and all that. And that's usually around 18 to 20 weeks, which is still within the time allowed for legal termination. Should there be a non-viable or a serious, defect that the parents do not want to continue the pregnancy. So we still have the time. So try to achieve good glycemic control, do all the anomaly scan and especially fetal echo, because the number one birth defect now is cardiovascular.
Yes, right.
Yeah. Chitra, I had one question. Am I audible?
Yeah, you
Yeah.
are.
Yes,
Yeah. So, given the fact that you told us that we are not really over medicalizing GDM, and the cutoffs actually need to be as low as possible. So, considering that fact, do you think that considering the Indian ethnicity, we need even more stringent cutoffs than the IIDPSG?
Interesting
Chitra?
question. Dr.
Chitra, you want to take that?
I don't have an answer, but it's a interesting question that I'm thinking about. I'm not really sure that will mean that a lot of centers from India have to come together to collect similar kind of data, right?
Similar kind of data, yes.
Yeah. So as far as the question, I mean, just to answer your question in a sort very important question, because when you look at the Indian ethnicity, we need to keep in mind that we already have low birth weight babies.
Right.
That a big percentage of our babies are already low birth weight, and a big percentage of our women are already low. I mean, they are low weight. They are thin stature. So while it is extremely important to talk about obesity and pre-pregnancy weight optimization and restrict maternal weight gain, we have this huge other problem of not. So that there I completely with the title of Chitra's talk, which is what we don't want to do is not keep these things in mind. And for example, if I diagnose GDM in a woman in the 8th week of pregnancy, early pregnancy, and then I tell her that you have gestational diabetes and you need to be on this diet, and she's already underweight. If we are not cognizant of that fact and we are not monitoring her weight gain and her baby's growth, we might actually be doing a great disservice. So we will be looking at the glucose numbers, but not at another important parameter. So it's really important to balance both.
Right. Actually, that might be difficult because when you're looking at weight and looking to have optimal weight, the glycemic load would increase by default.
Yeah. And then, so the answer is you use medications and bring down the glucose, but make sure the mother and the baby is growing well.
Growing well, yeah. Right. That's
actually
correct.
Both these spectrums have known to gain more weight. The overweight mothers as well as the underweight mothers both gain a lot of weight during pregnancy. I mean, in fact, it has been shown that the type 1 thin patients gain more weight than normal pregnancy because of the most likely because of the counter-regulatory mechanisms that happen. So thinner patients gain more weight as well as overweight patients gain more weight during pregnancy.
And they're also expected to gain more weight. So we ask them to get, that's also another reason why, they may gain more weight. So
right, absolutely.
You find both of that in the same patient as well, right? Where you have a patient who's gaining weight, but is still deficient in all the nutrients, protein, everything that is required for the baby to grow properly. So
absolutely.
we are maybe in the worst of both the worlds kind of a situation where
absolutely
with protein malnutrition and micronutrient deficiency, as shown beautifully by Dr. Yagnik's work, as well as struggling with carbohydrate overload and hyperglycemia as well.
Absolutely. So Dr. Arun Kedia has raised good points in the chat box on postpartum surveillance, where we are lacking in big way. And there are a couple of suggestions that we match the testing of blood glucose in the mother with the vaccines with the vaccination of the child, or come up with more innovative ways as to how we can catch these postpartum women. There is also one clinical question, ma'am, which says in the postpartum care, when would you stop the insulin and put the patient on oral anti-diabetes medication after delivery? I mean, I suppose that the patient had type 2 diabetes, was on insulin throughout the pregnancy, remains to be hyperglycemic after pregnancy, and now needs the change in the medication. So for till when you will continue the insulin and when you would shift her to oral.
Can we answer Arun Kedia's question first?
Yes, why not? Why not?
Only because that's my favorite area.
And before you answer that, Usha, I think that is something you've always advocated, to tie it up with vaccination. You've always said that.
Yeah, I've talked about it, but I also know that it's a giant logistic nightmare, because pediatricians are already quite overwhelmed and all that. But I think it's if we really very systematically design it and help them build the capacity of pediatricians and their that whole system, and we do that, and it'll also help the whole talk that Chitra did about the babies who are born to mothers with GDM. Because when a baby goes to a busy pediatrician, it's even difficult for them to address those the metabolic and other issues that the baby needs to be looked at, and not just a baby checkup. So this will actually help in both ways. But how we can think about it as a research project. The second thing that we are doing something small, a pilot, is when the mother leaves the hospital, we are giving her a 75-gram glucose screening packet with instructions on how to take it at home, 75-gram GTT. And they drink that and do a finger stick glucose 2 hours later and take a screenshot of that and send it to our diabetes educator. I'm just saying that that's one way of doing that. We can always send reminders through WhatsApp and messaging and a phone call. Everything can be done, including one of these things, which is sending them home with a 75-gram glucose packet. But more than all of that, I just want to say is probably the mothers have to be impressed right from day one when they get diagnosed with GDM that they are at greater risk for future type 2 diabetes, and again at risk for GDM and risk for cardiovascular disease. And I know that this is a favorite area of Chitra's. That language matters. How do we put this across to a pregnant woman? These serious matters across to her carefully, but definitely with the seriousness that it deserves from day one.
So I just want to come back to you and ask you from a public awareness point of view. I mean, I think very little chatter happens when it comes to pregnancy and diabetes in the public space. We each one of us, sort of talk in silos, whether it's obstetricians or whether it's endocrinologists and diabetologists or the pediatricians for that matter. But none are ready to talk to each other and say what should be the common areas of intervention. So I think it's time that we come out and say what are the common points of clinical and biological markers that we should look for a lady going in for pregnancy, which will probably amount to prevention of GDM to happen. And can we sort of put this in the comment domain that everybody has to screen this, whether it's pre or post pregnancy, and say, all right, if the pregnant lady is going for a second pregnancy or a third pregnancy, then is she optimized enough, and how long backwards she should start an optimization process to see that by the time she's ready for pregnancy, she's in the right frame of biology to see that she has a safe motherhood and a future child that is at a lesser risk for NCD. Any thoughts on this?
So, not my thoughts, but the Lancet has a paper on this where they have said that how do you define preconception care? They've said it can be defined in 3 ways. At an individual level, it can be just from few days to few weeks, taking folic acid, straightening this out and that out. And then as you go backwards from a more public health, like what you're talking, that takes going back into school and high school and college and healthier girls, because healthier girls become healthy moms and then give birth to healthy babies. So you have to go back a long way. But I'm just saying, realistically speaking, at least if women who are planning their pregnancy can give us just 6 months, we can do the basic screening, or they can get the basic screening done and put things in motion, and optimize things as much as possible. I mean, there will be no surprises like finding diabetes or finding them on medications they should not be in, or hypertension or anemia. So a good 6 months. So diabetologists, endocrinologists, OBGYNs, on the importance of contraception, how to prescribe it, and then on very basic stuff that we need to do for our vaccinations. Most of them are not up to speed, so we can get all this sorted. 6 months. I'll be happy if they give us 6 months.
So do we have cutoff points of clinical and biological markers that we would probably like to see in idealistic situations? And what would be these markers that you would, let's say you have 5 markers or 10 markers that you need to sort of straighten out and say every pregnant woman, and you put it in the public space, should look at these 10 markers to say that, are you ready for pregnancy?
Yes. Chitra, I don't want to.
You can add. So I think the top few will be detection of diabetes. So maybe a HbA1c good, if not a fasting and a 2-hour post meal, if not post glucose. Definitely hemoglobin levels, definitely thyroid levels, definitely blood pressure check, and weight with a BMI.
BMI, right.
I think that would be the bare minimum. We could have a more advanced panel as well, where we probably look at B12 levels, where we make sure that we are vitamin D replete, making sure that our iron levels are all right, and making sure our protein intake is all right, along with taking all the measures to optimize everything else that we've screened. Is there anything else you would
you consider doing fasting insulin levels or anything like that? Also,
not really sure fasting insulin would add any value greater than maybe a BMI calculation at this point. I think everybody here would agree with that. So maybe a waist circumference measurement would offer greater information than a fasting insulin level measurement.
Nutrition, anything to do with nutrition that you would look at?
Yeah, we did look at B12. We did
and iron levels.
Look at iron.
May I just say that, see, these are not possible under public health level. See, when you're looking at the country, India has something like 300 million plus women in the reproductive age. So it is impossible to get, all. I'm saying some of these things are aspirational. We won't be able to get it. But at least, like you said, minimum, we should be getting our hemoglobin, and we should be getting glucose, checking the blood pressure, and then getting a history on genetic disorders, medications that they are on, mental health, vaccinations should be brought up to speed. And then, of course, now they are talking more and more about environment and getting into that history and the social determinants of health. Just improving the basic health of the young woman and preparing her mentally also for a pregnancy should be will do wonders for our decreasing our type 2 diabetes risk.
Thank you.
So would you like to go to the question, postpartum insulin shifting to oral anti-diabetes medication?
So if it is an individual who has pre-existing type 2 diabetes, which saw an upswing in blood glucose levels during pregnancy, which required basal bolus, most women in the postpartum state can be well managed with a premixed 2 shots per day dose, because the insulin requirement has come down significantly. The OHAs, which are safe and approved for use in the breastfeeding phase, immediate postpartum, would be metformin and maybe shorter acting sulfonylureas like lipizide and gliclazide. So those are options that you can choose in women who might find staying on premixed insulin. And that is a very difficult phase immediately postpartum. So that is also something that can be considered. But in hospital monitoring itself will sometimes, in women who have GDM and not overt type 2 diabetes, show that the blood sugar levels almost move into normal range immediately by about the second or the third day. In those women, you can maybe even just tell them to be careful, monitor maybe once or twice a week and stay in touch and report to us if sugars are going above 180 to 200 post-meal. So we might need to start metformin. If you're worried that they might be lost to follow-up, it might make sense to keep them on a small dose of metformin at that stage, which could still be safer than being lost to follow-up completely.
I think the SELECT trial just came out. Degludec has now been approved for pregnancy by the DCGI. So it just came out.
The last question we'll address again by Dr. Arun Kumar Kedia, saying what's the role of pediatrician in preventing NCD? I think we have addressed this, and I'm sure we are aware that there was a data by Dr. Yagnik that the blood glucose starts going up in children at age of 6 years. Those children who are born to women with diabetes, their blood glucose starts going up at 6 years. So definitely pediatricians have a big role in detecting them at that stage and preventing complications in later life.
So these were the girls of the mothers who went on to developing GDM themselves.
Yes.
So that's a phenomenal study.
Result.
At 6, 12, and 18, yes. he showed that their glucose was, going up. So that, which is why I, prefaced when I started by saying that this is not just a medical complication of pregnancy, but it's actually, something pre-existing condition of sorts.
Right. Absolutely. So I think it had been a wonderful session, both academically, thought-provokingly, as well as clinically very important. I really thank Dr. Usha ma'am and Dr. Chitra on behalf of the IDEC team, which includes Dr. Sanjay Agrawal, Dr. Neeta Deshpande, myself, Dr. Nitin Kapoor. We're missing Dr. Archana Sarda here. She's busy with her son's marriage. But I also extend her, on behalf of her, a big thank you to both of you.
And don't forget Shilpa.
Oh, I'm so sorry. Thank you for reminding. Dr. Shilpa is an integral part of IDEC team too. And a big thank you to all the audience who joined in large numbers for this particular discussion, which was very interesting. I'm sure all of us have important take-home messages from today's discussion. If anyone wants to say anything, we have a stage here. Otherwise, I think we'll say good night.
Chitra and I reciprocate all of what you said. Thank you so much.
Thank you. It's been a pleasure to have you on the show. Thanks a lot.
Thank you. Yeah.
Thank you, everyone.
Recording stopped.
Hello.
Hi. Are we off the air, Neera?